What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. Brett, this is our second time having a live audience for one of our recordings, so no pressure here. So we just finished with our clinical neurodynamics course with Michael Shacklock. This is the second time Mike's been on the podcast, so what a pleasure to have you back in the United States. We're so happy that you were able to get here and teach this awesome course. It was unbelievable, the upper and lower dynamic hybrid course. And so we went over everything this weekend. It was pretty amazing. So thank you for being here. Can we just start off with, we actually had it last night at dinner. The waiter asked, what do you do? Or what is your specialty, Michael? So what is your specialty and what is neurodynamics?
Yeah, well, my first response when someone who's not involved in the area asks me what is clinical neurodynamics, my heart sinks. How in the heck am I going to explain this? It's been a lifetime of work, details, molecules to physics and stuff. But I try and simplify it, and the regular person who's not a health professional, they think they understand pinched nerve. And so I just say, look, my area is helping people with pinched nerves or learning how to diagnose and fix pinched nerves. Now, that is an oversimplification, but at least it gets the buy-in. And if you're thinking therapeutically, one of the things we've got to do is meet the patient where they are intellectually or cognitively and try and escort them or guide them to a better place. So that's actually the same strategy with this person we were talking to last night. It was a server at the restaurant, and I think when she heard that I was from Australia, it was like, wow, different. A foreigner.
She almost left her husband for you.
And so I said, my area is pinched nerves. And she, like a lot of people, I've had one.
Yeah.
They either say, I've had one, or I used to have one. Oh, sorry, I have one now. I used to have one, or I know someone who's had one. And she said, I've had one. Oh, what's yours? And she said, sciatica. And that's what I want to hear, sciatica. And I said, well, that is a pinched nerve. And so we kind of proceeded to talk a very small amount about it. But if I had to explain it to someone, I'd say pinched nerve, there's a little bit of extra pressure on the nerve and it gets sensitive and hurts, and we teach you how to reduce the sensitivity, unload it a bit, and help get it moving better. So that's kind of a broad start.
That's perfect. Couldn't have said it better myself. So today, we already had you on once, and we kind of talked a deep dive into neurodynamics, nerve physiology, all sorts of just awesome things. Today, we're going to take it a little bit different route. So we did this with Dr. Michaud. We're going to do it pardon the interruption style. So if you guys aren't aware or aren't familiar with it, Pardon the Interruption is a TV show on ESPN, and they basically do 2-minute topics. And so they get a topic and they'll talk about it for 2 minutes, and then at that point it's done and they're on to the next one. So we're going to do it with you, Michael, with some common neurodynamic diagnosis in the spine or in the body in general. We want you to give us your big hitters. Okay, so we want a quick 2-minute of the best clinical pearls you have for those, and then also maybe one or two, like palpation here is really important, or the upper limb tension test is really important here.
Or if the anatomy makes it unique for that particular region, little clinical pearls or quick hitters for those things.
Good.
Yeah,
absolutely.
So the benefit is, like with Tom's like you, he knows research on lower extremity mechanics better than anybody. So it basically forces him to they could talk for 3 hours about each topic, but instead we're going to do 2 minutes.
Exactly.
Yeah, this is throw the speaker under the bus.
Yeah, that's kind of what it is, honestly.
Exactly. So we're going to really test his knowledge. We're not quite sure if he knows his stuff.
Yeah.
So.
He's an imposter.
All right. So how we're going to do this is we've got it broken up into upper and lower extremity. Do you have a preference on what you want to start with?
Probably lower.
Let's do it. All right. You guys ready? Crowd? You can make a little bit of noise. Let's go.
Wow, that's impressive.
That is awesome. All right. So I got the stopwatch here. We're going to start off. We're just going to go right down the list here. Okay. So we're going to start with tarsal tunnel syndrome or tibial nerve issues.
I'm glad you said or tibial nerve issues, because tarsal tunnel syndrome is a group of symptoms. It's a syndrome. And what we know about virtually all physical tests, including neurodynamics, is there's not a direct connection between the medical diagnosis, which is tarsal tunnel syndrome, and clinical features and pathology and disease. And one of the tough times we have is doing a physical test, and it's not positive or not negative, yet they still might have that medical diagnosis. So you could have tarsal tunnel syndrome with the symptoms. You could do an ultrasound or an MRI scan. It might not produce or show pathology, but it can still produce symptoms because the behaviour of that tissue is abnormal. Now, to me, behaviour is a really important part because that gives us access to symptoms with movement. And that's our job, isn't it? We're physical health practitioners. Our job is to figure out what people's function relates to their symptoms. And so if you take tarsal tunnel syndrome, that's right. You can have an abnormal neurodynamic test, perfectly normal conduction, so the medical diagnosis doesn't exist, it's negative. Physical testing is abnormal, and yet you can have nerve conduction through that area perfectly normally, so you could get inflammation. The electrophys doesn't look for the right mechanism, negative, but what we see is the right mechanism for that person's symptoms. So you arrive in heaven, you're the angel, as I've said on the course, the angel says, you've been good. So you have a wish. And so that wish for me, the condition is diagnosis with a physical test for tarsal tunnel syndrome. It would always be palpation. We know that neurodynamic tests are not entirely sensitive for the problem, but you can put a lot of force on a nerve, feel if it's swollen, and reproduce symptoms with palpation that emulate some of the patient's mechanisms. And that's my 2 minutes.
Beautiful. That was perfect.
2 minutes, right at it.
That was perfect. Yeah. Okay, we're on to the next one. Peroneal nerve issues.
Peroneal nerve issues, for me, are not as common in our area as things like tarsal tunnel or radiculopathy. A clinical manifestation of a severe one would be foot drop. Now, that's difficult for us because foot drop can be caused by a lot of things. You can have a sciatic neuropathy. You could have a schwannoma in your sciatic nerve producing pressure in a foot drop. You could have lumbar radiculopathy as well. You could even have piriformis syndrome, a severe one, as the sciatic nerve might pass through one of the heads, between one or two of the heads of piriformis, and you can get compression of the fibula or peroneal part of the nerve. So for me, foot drop and that sort of thing, peroneal nerve is a difficult one. I've seen people with diabetic peroneal neuropathy, and that's nasty because they get a foot drop. No abnormality in the neurodynamic tests. They're perfectly okay. Palpation, perfectly okay. Now, that particular example was a diabetic neuropathy. I called the doc and said, look, I can't see what physical therapy is going to help this. And the doc said, well, what's happening with the diabetes? And I said, well, she tells me that she's not taking medication. And he said, well, that's the problem. She's got to manage her diabetes. So that kind of raised issues of general health, life strategies, medication and stuff. And so that put her out of the neurodynamics hospital. While she had a neuropathy, she did not have a neurodynamic problem because it's only physiology. It wasn't mechanical. And so I didn't want to treat her. It was more medical. And so, but the flip side is if you have a compartment syndrome, pressure on the nerve, if you have trauma in the area, that's exactly what we should be doing. So we would be doing neurodynamic testing. We would be finding out what provokes and is their symptoms. You're going to grade their level of function and use a progression to mobilise or decompress that nerve manually or physically with your diagnosis and treatment techniques.
He's good at this. That was 2 minutes.
That was 2 minutes on dot.
Yeah, 0.81 seconds. So, I mean, this is...
I'm getting feedback. You know when you talk to a patient and you start a sentence and they go, Oh gosh, I've got to change this now, because you're watching their non-verbals, right?
Yeah.
And you go, oh shit. Well, it's kind of not that severe though. I'm going to go in this, so I'm kind of modifying as I go.
Beautiful. Okay, our next one: interdigital neuromas or Morton's neuroma, neuritis, those types of things.
Okay. Are we timing this or?
Yep.
Well, okay.
Ready? Go.
Well,
He's keeping me on track.
I prefer without the timing myself. I can talk for years. Interdigital or Morton's neuroma. The interdigital neuropathy could be caused by other things other than Morton's neuroma. So the pathology and diseases, and Morton's is one of them. But you could have, so for example, biomechanical changes in the foot, so a dropped met head, and you get neuritis, but it's not necessarily neuroma. And so for us, I'm a physical therapist, and I don't have direct access to such investigations that would determine the difference. But for me, you'd want to know if you've got some sort of tumour there or whatever. And so with Morton's neuroma, even though we can't operate on them, and sometimes they don't. So we have function. That's our job. And as I say to patients, you've got two choices: you hurt and you don't function, or you hurt and you do function. And so the idea is that we would try and improve function to help their symptoms. And some of the techniques we would do would be what we call the innervated tissue techniques that we didn't talk too much about on the course, but it helps us become much more specific with the end tissue. And so if you have a third digital neuroma, you would use the third toe to do stuff to the nerve, and then you're going to use the ankle to do more things, and you could do a straight leg raise or a slump and add to it. You could do a toe extension, applying tension to the nerve, or toe flexion with the leg raise. So you could do sliders, tensioners, and remember that it's about the interface that's relevant to the nerve. So you'd need to know whether you've got tendon sliding distally, nerve sliding proximally, or whether you want to even compress the bone onto the nerve and do a sandwich through the bone, a nerve sandwich with the met head, for instance. So there's a ton of things you can do there to figure out what angles you need and what pressure areas and directions, forces that you need for that patient. And so you have to change them and figure it out, and you could modify those accordingly.
I mean, this is like clockwork, Brett. He's just absolutely crushing this. So
way better than Tom was.
Absolutely. Okay, our next one, lumbar spine nerve root. So we can talk about nerve root neuritis. We can talk about nerve root disorders. We'll just talk about nerve root in general.
Yeah, the lumbar spine is low back pain is one of the most common causes of absenteeism in work. It's one of the most common health problems. Okay, now within that, lumbar radiculopathy is a subgroup. Now, for me, again, one of the most important things that we have is function or dysfunction. Now, you can have different people with the same medical diagnosis, lumbar radiculopathy, but it could be in different places around that nerve root, in different sizes and shapes, different pressures, and each nerve isn't always uniform, and they may respond differently to that amount of pressure. And so for me, reopathy is only the medical diagnosis. We use it, of course, for safety. Of course, we don't want to press on nerves that are already pressed on. And so if we're thinking of functional techniques, the cause is typically pressure, too much force. And my criticism of just doing nerve flossing or neural mobilization for such things is it doesn't take into account the mechanisms in their entirety. And the one is pressure, too much force, let's mobilise the nerve, which also applies force. So to me, the logic is a problem, and if we're thinking of descriptors for our results, you could say curative. It's not a curative technique. It's not entirely a corrective technique. It's probably an adaptive technique. So it probably helps the nerve root adapt to the compression, but it's not enough. Why not consider unloading the nerve root? Because that is the problem, too much force. So why not open the foramen, unload, which we know reduces pressure, we know it improves blood flow. It's all been measured intraoperatively with people with disc hernia. And why not unload the nerve root from the newly validated mechanism, which is contralateral neurodynamic testing, where if you do a contralateral movement that pulls on nerve root, it removes the cord down along the nerve root line, reduces tension, and unloads. So to me, unloading is a really important part of giving people pain relief with lumbar radiculopathy.
Great job. Beautiful. These are easy, Brett, because we just kind of get to hang out here and just listen.
I know, this is perfect.
We'll just drink our seltzers with the rest of the crowd and, hang out, right? Cheers.
The only
Cheers.
thing, the only
We
thing,
got one coming later, though. Misconceptions of neurodynamics. That one's going to be...
the only thing they need to do with this is double the alcohol content.
Just drink more.
And don't worry, we got more. We can do that. All right,
No one's ever gone thirsty on our podcast.
That is true. So that is true. All right, our last one for the lower extremity, piriformis syndrome. Piriformis in general.
Wow, piriformis. It's actually quite controversial. A lot of people don't believe it exists. I was talking to a neurologist over in Sweden Finland a while ago, and his wife's a physio, and so he's been having these debates with her, and he actually didn't believe that it exists. But if you go to the research, there are studies that show impaired electrophysiology of the sciatic nerve in the presence of compression by piriformis. The next layer of evidence is surgically they see compression of the nerve and they can decompress it. So that's kind of pretty good. And you can also get scar tissue around the nerve from local trauma. So for me, I'm okay with the idea of a sciatic aspect to piriformis problems. Now, what you call piriformis syndrome is another story. You might have the Salmon approach, which might say you could get a hyperactive short one. That's a muscle diagnosis, of course, or a hypoactive long one, which would relate to other motor control or movement issues. But when I'm going to focus on the nerve, which is sciatic nerve, either irritation or compression due to piriformis there. So for me, again, why not in an acute severe pain patient unload the tissues? And so what you can do is unload piriformis below 70 degrees. It's an external rotator, so you do passive external rotation as an unloading technique, and then as you get higher, you could do internal rotation as an unloading technique. But for me, one of the golden techniques, if as I said to you guys on the course, if you live with one technique for achy, breaky buttock pain in the athlete, it's all they have with high performance. You can test piriformis with the nerve. And to me, that is 2 + 2 = 5. That is Gestaltian, wink, wink,
Oh,
wink.
there you go.
And that is a golden technique for diagnosis and treatment of a muscular aspect to nerve pain, piriformis syndrome with a sciatic nerve 210.
Yeah, we did that through a slump test, right? We did.
Yeah, sorry, yeah, that's right.
Yeah.
Yeah, that's right.
Mm-hmm.
I'm thinking I have to stop it too. So.
At this
some
point,
test.
he's almost like playing into it. But you know how weird he
He's
was at
swerving into
first?
it.
Yeah, now he loves it. So this is awesome. Okay,
I want more of this.
great job with the lower extremity. Any quick hitters? I'll give you a minute or two that we missed here in the lower extremity that you're really passionate about.
We left out Searle.
Yes. Okay, I can talk about the sural nerve.
Okay.
Sure, do it.
Okay, sural nerve. It's a obvious electrophysical diagnosis if you want a neuropathy, but I don't see a lot of sural neuropathies. I see more commonly, or have seen more commonly, local trauma or overuse producing inflammatory or mechanical irritation of the nerve, which then produces pain down towards the lateral heel into the lateral part of the foot. So to me, a critical element is palpation and neurodynamic testing with or without muscle contraction or stretch, because you're then combining them and then you can often find it. So standard straight leg raise with dorsiflexion often does not find it. You need to do dorsiflexion inversion, because that's where the nerve goes to load the nerve as it passes through the tunnel there. And so I've seen people who, for instance, have pain in the area. You don't suspect that it's neural because there's no pins and needles. There's no numbness and stuff like that. So if you get in there and palpate it, it's critical that you go along the nerve up to its tunnel. And that's often underestimated, that tunnel part. And so you follow the nerve up into the tunnel, press on it there. Even if that doesn't produce a problem, it's not enough for some people, you may then need to do the sural neurodynamic test, say inside lying, wind up the straight leg raise, neurodynamics, etc., and the dorsiflexion inversion, and that's when you often find it. That's because you're pressing on the nerve as the muscle is stretched, so you're doing tunnel plus nerve in that situation. Then, if you look at the gastrocs or other muscles in the area, you might find it's tight. Good. Dorsiflexion inversion, stretch the muscle as you're doing a nerve sandwich or something to the nerve with your hand. So don't underestimate the combination of manual testing and nerve techniques with your fingers or your hand. So to me, that's really useful. I've seen people who have just not done well until we've done that sort of thing, and we needed to get right into it using a number of different tissues at the same time. So that's what I'd say about sural nerve.
I got a fun one we can add in. Kind of a hot button subject over the last 5 years has been a resurgence of Main syndrome. The cluneal nerves coming from the thoracolumbar junction into the glute area. My opinion is I feel like it's a little bit overstated, but I'd be curious to hear how often you've seen it. Does it matter? What your treatment ideas would be for that?
Yeah, I've probably seen a couple. I must say that the one that I saw decades ago was we thought it was a posterior primary ramus type syndrome, which Bogduk talks about, as the posterior primary ramus comes around the back of the vertebra and it's got a little ligament over the top of it. So we would think it was that, but I'm looking back on it. I think that probably was, but it links to the cluneal thing, because this guy had numbness just to the left of his spine in the skin. That's definitely posterior primary ramus, but further out and along the hip and everything, and posterior pelvis area, cluneal nerve. Diagnosis: fingers. Get your hands on it. But truthfully, I don't actually see a lot of them. But maybe because I'm not looking enough.
Right.
It's a case of looking, you shall find. And so I could probably get into looking at it more. But the key for me is palpation. I don't reckon you're going to do a whole lot. We can't do anything with the legs, because remember, when you do a straight leg raise, it's that triangulated mechanism that we talk about, where you'll get a decrease in tension if it reaches a cluneal nerve, it'll decrease it.
Right.
Because that's that Y mechanism.
Yeah, it's kind of paradoxical.
So it's an upside down thong, actually, but don't tell anyone. And so basically, down you come with the cord, and as you bring that down, you shorten the cluneal nerve. If it's connected directly, it moves. So you're going to reduce your diagnosis by doing a straight leg raise. So don't do any of that. You do the slump test from above, and then you do your manual techniques on the nerve. You might even do contralateral lateral flexion to pull on the fascia and the nerve to get at that area. So to me, it's very local. So the legs are out, and then you do contralateral lateral flexion slump, like a 3A technique that we talk about on the course, but without the leg. And then you do your manual diagnosis with your pressures and your palpation.
Perfect.
To me, that's really useful. And neurological, you can do the pinprick on the skin and stuff like that.
Beautiful.
Nice.
Let's cross out the lower extremity. We're done with that sucker. Great job. That was really strong. Okay, let's move on to the uppers. Okay, so we're going to start with the easy one, carpal tunnel.
Carpal tunnel syndrome.
Median nerve.
Ever heard of it?
Yeah, I've seen a couple of those. It's the most common neuropathy, isn't it? It is an important, huge health problem, but to me, again, when it comes to carpal tunnel, tarsal tunnel, to me, a really important part is figuring out whether they have an opathy or a syndrome that relates to dysfunction. And so if we look at people who have, say, compression in the wrist, they get edematous, they get larger, they get hypersensitive, and so we can use neurodynamic testing or treatments to reduce edema in the nerve. And the research shows that if you mobilise the nerve, even in fresh cadavers, believe it or not, if you put some Evans blue or some dye in the nerve, let it sit there for a while, it doesn't really distribute very far. But if you mobilise the nerve, it does. So we now know that there's a good reason for edema redistribution in neuromobilisation for carpal tunnel syndrome when the nerve's edematous. But I think there are subgroups, and I must say, I would love to say to all my patients, yeah, I can fix that, because that's what we want to do, isn't it? I don't know about other professions, but I think physical therapists are really lousy at saying, I've done as much as I can. Because we want to help. We're a helping profession. And so, but I think we can subgroup them. And one of the ones that I personally don't do very well with is the ones with severe neurological deficit. They're the ones who have paralysis, or their muscles are getting weak. Wasting of muscle, loss of ability to hold things, they're dropping stuff. And you ask them, does it change with position or activity? And they say no. That's not easy for us, because it doesn't look like we can unload that nerve easily or mobilise it for benefit. And so if they've got a severe neurological deficits, have been a long time and invariable, unchanging, then I'm not very keen on treating that person for a long time, because the research on surgical results are actually not bad. Yeah, pretty good. So.
Yeah, they do decent.
Yeah. And so
Michael Leahy, one of our other guests, he is of the belief that a lot of carpal tunnels cases are being misdiagnosed for pronator entrapment higher up. Have you found that to be the
Good
case?
question. That's a really good question. I think for all carpal tunnel syndromes or suspicions, you've got to palpate the median nerve of the elbow, because the nerve tract, if you will, goes to the same area. And so if you get a problem in one area, it could affect the other. And we know that with the double crush mechanism, you can get a spread of pathophysiology along the nerve, and it can be vulnerable in another area. The research on that's been a bit sketchy until recently, where they've actually been able to reproduce it in an animal model. And so it's kind of looking a bit better.
So the double crush does exist.
The gold standard is electrophysiology,
Right.
and the early studies didn't find electrophysiological changes in two areas, but the experimental research now has found that if you compress one area, it does produce electrophys changes, but it takes less force in another part of the nerve to produce the same thing. And so it's looking like, from a biological perspective, there could be a connection and a relationship. So advice here, taken from what you're saying, Brett, palpate the median nerve of the elbow with pronator, because that could be part of the same thing. So yes, good comment.
You went 3 minutes there, but
That was my fault.
I'm gonna
Yeah.
blame Brett
Yeah.
on that one.
Yeah,
So
that was my
that
fault.
was 100% him. So
Oh, wow.
we're gonna move on to radial nerve. Specifically, I'm generally curious, how much does that contribute to lateral epicondylitis or any epicondylitis
you asked.
symptoms?
Yeah, I'm glad you asked. We do have it said that the little spot pain over the common extensor origin is from the radial nerve. I'm not on the same page here, because if you're pressing on a tendon and it hurts the tendon, it might be the tendon. Funny that. And so if you then press on the nerve and it does not reproduce the tendon pain, it's probably not the nerve. If you take it through to neurodynamic testing, I've seen these people with common extensor tendinopathies, and some of them do get reproduced and some of them don't. So you might have a contributing factor. But if you do neurodynamic testing, perfectly normal, neurological testing, perfectly normal, palpation, perfectly normal, it ain't the nerve. And unfortunately, we're in a world these days where what we identify with can be misconstrued as a fact. Now, I'm not very keen on that. If all the evidence presents as not a nerve, you've got to go with it's not a nerve. And they do not go to the neurodynamics hospital. They stay with the tendinopathy hospital. Okay, but there is a group of people who do actually have contributing factors, or it's one or the other. Now let's go to the other extreme, which is supinated tunnel syndrome, not a tendon. These people have anterolateral elbow pain. It's not that spot pain. They do get pain there, but it's not the spot pain. And then they do get reproduction of clinical symptoms, and you palpate the nerve, and it does reproduce them. And those ones, every now and then we've been able to follow them through to ultrasound or MRI. They do have compressed radial nerve at the elbow. And so for me, follow your observations in spite of social media.
Preach.
What?
That's insane.
So to me, physical testing skills remain critical in clinical practice.
There was a paper. Did you see that paper where they did a Mulligan mobilization procedure for lateral epicondylitis, and then they added radial nerve,
Okay.
and it actually did improve the overall results.
Okay.
So maybe they kind of had the fleas antics. Maybe they had both things kind of going on. And maybe.
Yeah, well, I'd like to. I haven't read the paper, but I would like to know if they did testing to see if they had a radial nerve problem.
I don't. I think they just added it.
Yeah,
in.
sure.
I'm pretty sure.
Yeah, sure. Now, actually, in some ways, I like these studies, but one of the difficulties we have as health practitioners is there are two types of treatment effects: non-specific and specific. Now, the non-specific could affect your brain downward, of course, and it's not to say don't do it. Of course, you can. And I think the Mulligan approach is really good at getting multifactorial input. It's really good at movement of the joint, movement of tendons. It's actually a you can do it manual therapy approach, or it can work. And that's really good from a multi-perspective direction where it could affect a large number of mechanisms. But from physical therapy perspective, we often put a clinical trial in the situation of not really knowing what's wrong. And that can be helpful, but I'm a sort of what's wrong guy and work from there. Just not necessarily localising it to that, but you can do a lot of non-specific stuff, and I would really like to know what else was specific about the paper. And admittedly, I've not read it, but if it works, you got that other validity, which is a clinical trial show it works. Then later we figure out why.
Yeah, because
So-
it
so
could
you
just
do it
be
that
that
way
you're
too.
lengthening the extensors through the
Yeah,
radial
yeah.
nerve.
You're doing a lot with the malignant
Yeah,
approach. And so if it works, fine, do it, and later then figure out why.
Cool.
Beautiful. Let's stay in the elbow. Ulnar nerve at the elbow. Specifically, the hypermobile.
Yeah, let's go hypermobile.
Yeah, the unstable on the
Yeah,
nerve.
exactly.
I'm afraid my heart sinks when I see that one.
Oh, good. Same.
You know, the unstable ulnar nerve is actually really fun to fiddle with. You can dislocate them, you can put them back, you can put them in a different scapular position to ease the tension off the nerve, and often they don't dislocate or they don't do it as severely. So you can really modify how if it dislocates by scapular and shoulder position and stuff. But the reason it exists is possibly two. One is that the fascia restraint around the nerve is insufficient, or the sulcus and the tissue around there and the epicondyle just is conducive to it moving over. And so I personally want to know if it's hypersensitive, if it's bigger, if it's inflamed. And you can see this on ultrasound, of course, but you can actually palpate it as well. It's quite superficial, of course. You can see and feel swelling in the nerve and whether it's hypersensitive. I would also want to know if it's in the tunnel under flexor carpi ulnaris, or whether it's actually in the sulcus and it's instability.
Right.
And so I would palpate the different areas and figure out which one is which. But unfortunately, I don't know how to stabilise it. I've taped them, I've done strengthening, I've done elevation of the scapula. Now, if you have a baseball pitcher, they can't elevate their scapula another inch just to ease their ulnar nerve. It wrecks their technique. And so, personally, I find it really difficult. And if someone had a recurring problem like that, as I said before, the three contributing factors can be pathology, no real pathology apart from maybe swelling. It's not abnormal, but function or dysfunction, that's what it is because of restraint. And pathology might be that it doesn't have the right connective tissue around it, and provocation. So you've got a baseball pitcher who's got a slightly unstable nerve, could be a serious problem for that person. But for me, I'm not a pitcher, and it wouldn't bother me necessarily.
And it's like 11% of the population, I think. So
It's well,
pretty
actually, that could be considered an asymptomatic pathology or dysfunction or instability. Now, not all dysfunctions hurt until they're provoked, and so I personally don't find that an easy problem. And I know you have quite a high prevalence of Tommy John surgeries and other things like that. And so I think that's a whole new discussion about whether they get a surgical intervention.
And then, like you've talked about before, if you've had the ulnar nerve relocation surgery, then your neurodynamic testing now changes. So now that becomes,
Okay. Now I know where you want me to go here.
Yeah.
Okay, so when someone has a translocated ulnar nerve, he's going, Michael, you missed that one.
hint.
And so let's say someone has surgery and has it transposed or relocated anteriorly. What is your neurodynamic test post-op? It was the ulnar. What is it now? Yes, it's the median neurodynamic test, because now the biomechanics have changed because the anatomy's changed. It's now located on the front of the axis of the elbow. So now your new reassessment technique and maybe treatment is median neurodynamic testing and treatment. So that's a really good example of following the biomechanics.
And there is all kinds of movement issues in the ulnar nerve when they relocate it after surgery. I mean,
Oh, really?
I can
Okay.
speak from experience with post Tommy John. Yes, like
wow.
almost 100%.
Really?
Yes.
So is it scar tissue, or do they think, or sensitivity, or?
No one's really said.
Okay.
Yeah.
So to me, the skills we would need to that is good understanding of neurodynamics, progressions for a diagnostic category. So it's probably going to be a tension dysfunction because it's inflamed and it doesn't respond to tension. But sliding could be really useful for that patient to ease their pain. But that's a median nerve slider, it's not an ulnar nerve slider. Yeah, so progressions. Now, having said that, look, we do talk about different types of diseases, pathologies and stuff, but actually the fundamentals of neurodynamics don't change. And so you would look at opening and closing, whether it's getting compressed by pronator, because it's there anyway, they've got a big pronator. You would look at to see whether it can slide, whether it can tension, and so forth. So the method is actually the same.
Right.
Just the mechanisms, you vary it according to the mechanisms.
Beautiful. Let's work up to the shoulder. How about brachial plexus traction injuries or stingers?
Yeah, they hurt.
Good answer. Next.
I've actually had one myself.
Yeah.
And I must say, ooh, the pain. And the paralysis afterwards really worried me, and finally it came pretty good. But the idea is that nerve tissues usually can tolerate approximately 20% elongation, 20% strain, which is 20% more than its resting length. Because beyond there, the connective tissues of the nerve start to break. So if you did a histology study where you elongate it to 18%, cut it in cross-section, looked at the cells and the connective tissue, it'll be okay. But if you go way beyond there, and clearly that's an injury that does that, it's a traction injury, the connective tissues of the nerve fail, it breaks, and then you get a discontinuity of axons. And you've got those three grades. You've got a neuropraxia, axonotmesis, neurotmesis, as a classification of pathology that's been matched with clinical symptoms in earlier research. Now, but the problem is that if you get that might be a violent injury, but if you get a sustained positioning, you don't need 18% because you've got the 8 to 15% elongation for blood flow. So it kind of takes you out of the positional thing, goes you into the tissue failure range. Now, whether it improves is a really difficult question. I mean, in neurology circles, they kind of look at 2 years. There's a 3-6 months range, then a year, then 2 years. And usually they say, if it's not really come right within about 2 years, it's going to be really difficult. And I personally have found people improve a little bit after that, but it's usually indicative of an incomplete neurological recovery. And so would you do nerve flossing? Or would you do neurodynamic technique? I've seen people with neurological impairment in other neural problems, and they stretch the bazinga out of these nerves, and they can actually improve. But I can't put people in that situation because it's a professional licensing safety issue. And so I will probably do flossing, and I wouldn't normally do tension, but I'm going to take you. Can I go beyond the 2 minutes?
Please.
Because there's a really, to me, an incredible study that I like to review sometimes. There's a study where they did neural elongation techniques to 6%, 9%, and 12% and measured the blood flow. We know that it deteriorates during the technique, but what was really interesting is that afterwards, one of the values produced hyperemia. The two others didn't. The 9% didn't, the 6% didn't, the 12% didn't, the 9% did. That is not a graded response, it is a dose-dependent response. That is fascinating, and this is in a neuritis model that produces wasting of the muscle. And so these are degenerative nerves, or they're failing nerves in conduction, muscles getting wasted. So they weighed the muscle, they also did an analysis of a trophic factor that we talked on the course about, trophic factor that is produced by the neuritis, and it tells the muscle to get wasted. So wasting in neuritis is not a passive process. It's not a failure of conduction into the muscle. It's an instruction given from the nerve to the muscle. Get wasted, man. Keep drinking. Okay?
That's all I heard, is get wasted.
And so that's an active process that has a dose-dependent response. That's where we have to be for plexopathies, plexitis, and neurological impairment.
So if we're seeing like an American football player who, we see it a lot when people obviously they make a hit with their shoulder. So then if this could be a 2-year process, like is there any danger in them playing, let's say in a month, even though they might still be having some symptoms? Do you feel like you got to shut them down, or what does that kind of look like in the management?
I think that if they can protect it with their traps and other contractions, then I don't think that's a big hazard, except that you're not going to move as well because you're partly... Are these people with neurological deficits?
Maybe like getting better, but still some. Maybe
Paresthesia.
Yeah.
Oh, paresthesia, so it's still something going on. Yeah, I'd want to know if it's electrophysiologically they're okay. But if they can protect it, I can see scope for just introducing a little bit more activity earlier.
Right.
But must be protected. Because you do it again, because your lack of contraction could be much worse.
Right.
So that's a very fine line, which personally I don't know the answer to, but I would think that if you can protect it well, you might be able to get them back a bit earlier,
right,
as long as it's safe. But I don't know if it's safe.
Beautiful. Okay. We made it, our last one.
Oh, wow.
Isn't that crazy?
Oh, That bus is approaching rapidly.
I know. Cervical spine nerve root.
Okay, yeah.
So we talked about the lumbar spine, which is going to probably be similar, but cervical spine, how about that? Any clinical pulls there?
Yeah, cervical spine, we know in some ways is similar to lumbar. The main thing from neurodynamic perspective is they're geometrically different. So if you look at what we've done in extrapolations from lumbar into cervical, the angle of the nerve roots coming off the cord is different. At cervical, it's about 60 degrees down from horizontal, or 30 degrees from there. But in the lumbar region, it's almost parallel. And also the cord in the cervical region doesn't move as much. And so the geometry and the movement suggest that the contralateral unloading techniques probably aren't going to be as direct as they are in the lumbar spine. So we see the study we did just fantastic results for unloading and neurodynamic test responses. Virtually 100% of our subjects got a reduction compared with the control group. But cervical spine is not quite the same because of those angles. Now, Alison Bell, who's a physical therapist in South Australia, did a study on neurodynamic test responses. So you bring the arm out to a neurodynamic response, you do a bilateral straight leg raise, and it produces a response in about 67% of subjects. But what was interesting in our studies, we showed that the cord only moves down half as much with one straight leg raise as both. So if you want to unload the nerve root in the C-spine, use both legs. It's much more direct. It doubles the amount of unloading possibly in the cervical spine. The question we have is that we see it a lot in the lumbar spine, which produces great benefit just anecdotally, but we don't know how much that will produce in the C-spine. But if we're thinking of unloading nerve roots for pain relief, you could do contralateral as we discussed, but if that doesn't work, do the legs. It's a great option in some people. So that's the kind of one thing. The other thing is the space for the nerve root's not as big in the cervical region, so I'm kind of a little more hesitant about cervical, but still try it, because in the end it's about n equals 1. Because if that works, you beauty, go you Parker, this sort of stuff.
I think too, a lot of our listeners, they've been trained in McKinsey or MDT, and a lot of times those are closing procedures, and a lot of times if that's not beneficial for the patient, then we can go into the static openers, which can be really beneficial for those cervical nerve roots,
especially the tricky ones.
Look, there is some overlap between neurodynamics and McKinsey, but I feel that if you do a unilateral flexion technique in the C-spine or lumbar, central flexion technique, and then do contralateral, that's a unilateral emphasis. So I think that we will hypothetically opening the foramen more, unloading the nerve root more in the in a unilateral technique than just doing extension or flexion. But the key thing for me is neurodynamics has a traditionally applied force to a nerve that's already forced on. Unloading is the new thing. First aid, we do it in MSK. We've got to do it in nerve for pain relief. That's really important. And our study showed less opioid consumption, less medication consumption, better functional outcomes, better pain outcomes for unloading techniques in this particular lumbar radiculopathy thing. I know that's not cervical, but we're going to apply it to cervical in the future.
And today we talked about the way to get the maximal opening in the IVF would be in a sagittal plane flexion, in the coronal plane, opposite lateral flexion, and then contralateral rotation would give you the most diameter in the IVF.
Yeah, now that's really important, because remember the IVF is a collection of functional units that we don't, the individuals of which we don't focus on. And so if you're thinking of facet opening, it's different from foramen opening. And so if you're thinking the usual line of reasoning is MSK is causing the nerve, fix MSK, nerve should improve. Perfectly logical, but this is a case of model 2 or model B of neurodynamics, where the two systems actually compete in their requirements. The mechanical's lack of extension or closing, the hypothesis mechanically would be improved closing, but the nerve can't tolerate it. And so often we do the opposite, and that to me is really important, because it's not about the disc for the nerve root necessarily, it's not about the facet joint, it's about just transient unloading, and so far there's been no complications with discs. So we're kind of deliberately omitting treatment to MSK just so we can unload the nerve, pain relief.
Right. Can I add one on? Yep. Let's do thoracic outlet syndrome with the baseball player. So it's kind of a hot button subject within Major League Baseball right now, where we
Nate
have
Dogg in the crowd right there.
Yeah, he's missing his first rib. So
okay.
They actually, the surgeon.
Oh, I wonder why I couldn't find it.
They actually give you your first rib. I'm not joking.
Oh, really?
Yeah. So the surgery's pretty invasive. So they take out your first rib. They're removing part of the scalenes and a lot of times part of the pec minor also. So it's a real invasive procedure. However, the players actually do get back. Like, say, it's kind of shocking to think, especially with like scapular mechanics, that you could remove part of your pec minor or all of it and still be able to function well. So my guess is we're probably over operating on it, but do you have any clinical pearls on how to diagnose it, treatment, and some ideas with the overhead athlete and thoracic outlet syndrome?
Yeah, I certainly do. The thoracic outlet syndrome is like a pathology medical diagnosis related to plexus and subclavian and all those sorts of blood vessels in the area. But let's just take it through to function. Now, these people, obviously they get compressive problems, maybe through anatomy, of course, but what we see a lot of is pain, and it's not necessarily so compressive. And so we're kind of in that grey zone between function and pathology. Now, in the thoracic outlet syndrome, there's different neurodynamic models at different parts of the thoracic outlet, and that is a big problem for diagnosis and treatment, because we think that if we just apply tension to the nerve, it's getting all the mechanisms along through the thoracic outlet, but it's not. Scalenes is model 1, and that is tighten your scalenes and you press on the plexus. So what's bad for a hyperactive scalene is also bad for the plexus. Model 1, they're cooperative systems, meaning what happens to one also happens to the other. But the further out in the costoclavicular space, it's the opposite. If you get a hyperactive upper traps, hyperactive pec minor, the costoclavicular space opens and unloads the plexus. So if you correct it, you are loading the plexus. So what's good for MSK is bad for brachial plexus, and that could be an underrated, underinvestigated phenomenon, and particularly in the more outer part of the thoracic outlet. So I'm really keen for clinicians to figure out what's happening there, so that you can apply the second model, which is open. Don't worry about MSK for now. Let it settle, and then when it's settled, the plexus, when it settles, then go through to MSK, and so it's actually the same as a nerve root, but we apply it to outer part of the thoracic outlet.
And it's kind of became a diagnosis by default, at least in professional baseball, where they have a clean cervical MRI, their shoulder MRI is also clean. But what's interesting, sometimes they don't have paresthesia, they don't actually have pain, they kind of have this dead arm feeling. And these people that are in this subgroup, they're going through this procedure, and they're actually noticing like quite a change in their symptoms in a good way. So it kind of makes the diagnosis a little bit more confusing, because you don't have the pain component, you don't have the paresthesia. So do you think that through neurodynamic testing we could flush this out?
Yes, well, that's possible. Now, thinking of the symptom, heaviness or dull or loss of feeling,
or loss of performance. Yeah.
So I'm a really big fan of reproducing the patient's mechanisms, because that's really that's the battlefront. Okay, and so if someone has a symptom down their arm, it could maybe neural, maybe not, but let's just reproduce what they do. So I would get them pitching just before you see them. Make sure it happens, and then see them when they're feeling the symptom. Because often if they sleep overnight, come to your clinic in the morning, it's often not there.
Right.
So timing is one of the things that you can use to sensitise a neurodynamic test. Okay, timing is one thing, and provocation or repeated movement. And so in the say a situation where you can put them in the end range position. And now, I'm thinking this is looking a bit ischemic because of the heaviness and the widespread symptoms.
Makes sense, yeah.
So I would put them in the neurodynamic position for quite a long time, and maybe even put them in a pitching position which is extreme, and hold it there with neurodynamics. So I would suspect that they're closing down their costoclavicular space as they go backward. Would that be right?
Yeah, that's right.
And so I would put them in the closed position, the costoclavicular maneuver, and then hold it there, and then do the neurodynamic test, and see what happens. I suspect that if you've got a bunch of them, some of them would be reproducible more effectively with those extra test techniques. So you're kind of reproducing what they do and sustaining it. It's kind of not exactly what they do, but you would sustain it probably. So if they're practicing pitching, then they're on and off.
Right.
But if you can hold it there, you might bring that on earlier and see what happens.
Nice.
And you could actually do that as a post-op evaluation. You could do it as a pre-op and see if you can change it and maybe prevent surgery. I don't know whether that's possible, but to me, there's a lot of potential for reproducing relevant mechanisms in that patient.
I think too, I mean, you pointed out today, which I thought was fascinating, that you can have like axonal compression, but you can also have like a blood flow issue within the nerve, and I mean, that might change the mechanism of why we're, having symptoms, not just in TOS, but in peripheral nerve entrapment in general.
Yeah, absolutely. And so I'm a big fan of the general rules of the system, but specifics for different cases and different anatomy, biomechanics, and so forth. It's both.
Yep.
Perfect. What a good conversation. Great job. You crushed it.
Thank you.
2 minutes, you were a little daunted by it, but I think you pulled it off pretty dang good. So
Thank you.
We covered a lot of things. Michael, thank you for sitting down with us. I know it was a long day, long weekend and talking about neurodynamics. Thank you all for sticking around and hanging out with us, number one, and for being here. I got to give a subtle plug because I was the bad guy. Brett, he gets to be the good guy. I was a bad guy that kept about 10 or 15 people off of this course. So if you were on the wait list and weren't able to get it, we do have 2 awesome opportunities to see Michael live and in person. The first one is in 2023. They're both in 2023, January 4th through the 6th. That's going to be in Mesa, Arizona at the Cubs training facility, which is Sloan Park. And so that'll be an upper and lower hybrid, level 1, just like we did this weekend. Then, if you're on the East Coast, the next week, January 10th through the 12th, we're going to be in Jupiter, Florida for the same exact thing. So we're just we get to hang out with Michael for basically 2 straight weeks, and I can't wait for that. So that'll be.
Then we have in May, Bob's helping us with Modus with Gestalt. Myself, Shirley Sarman, and Michael are doing a seminar together here in St. Louis.
That's right. So, and then we loosely organize a Neurodynamic Solutions Ultimate Summit that'll be in St. Louis in 23-24. And so, we got some awesome ideas and some awesome things that have come together this weekend, and we're appreciative.
It's amazing what wine consumption can do for the creativity.
That's exactly right. So. The goal is for us to maybe drink some more and find some more stuff, and then maybe do another podcast. So we'll see.
Thank you, man.
Yeah,
thank you very much.
Thank you so
great
much.
job.
As always,
absolutely.
neurodynamicsolutions.com. Did I do that?
Yes, that's correct.
Yeah, neurodynamicsolutions.com for all the awesome things. You put out so much good information, and we're always appreciative of that. gestaltedu.com/courses for all the upcoming courses. And as always, like, subscribe, unsubscribe, subscribe, leave a review. Let us know how terrible we're doing or good, either one. And thank you all, the audience, for being here to hang out with us.
Yeah,
and,
they're awesome.
Safe travels going home, guys. So
Thank you.
Thank you all. All right.
Absolutely.
Good luck with patients, guys. Go back and listen to these a couple times because there's some absolute clinical gold in there. So have a great day. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.